In the late 1930s, hormone science carried a new promise. Researchers understood that estrogen influenced the reproductive system, and they wanted something they could measure, bottle, and control. Out of that push came Diethylstilbestrol, or DS, a synthetic estrogen made in a lab rather than taken from animals. It was potent, it was inexpensive, and it could be produced in large amounts, fast. Those traits mattered because pregnancy loss frightened families and frustrated doctors. Miscarriage often arrived without warning, and medicine had little to offer beyond rest and reassurance. So when a strong, reliable estrogen existed, it looked like an answer. If hormones helped maintain pregnancy, the thinking went, then adding more at the right moment might steady the process. The goal sounded simple: stabilize pregnancy by chemical support. The hope did not rest on a proven cure, but it still spread quickly. DES seemed modern, scientific, and controllable, a drug that could turn uncertainty into intervention. A cheap hormone also meant it could move beyond the lab and into everyday practice without much resistance. By the end of the decade, the idea had taken shape in plain terms. A synthetic estrogen might prevent miscarriage, and pregnancy might be protected by prescription. In the early 1940s, the idea moved from theory into everyday medicine. Miscarriage and stillbirth already haunted pregnancy, and doctors faced few tools to stop them. DES, a synthetic estrogen, looked like a practical answer. It was easy to make, easy to prescribe, and it fit a simple belief. If pregnancy needed more hormonal support, a hormone pill might hold it in place. That belief carried weight. So DES started showing up in prenatal care, especially when a woman had bleeding, cramping, or a history of loss. Some doctors also gave it preemptively, treating fear itself as a risk factor. The prescription often followed a schedule that increased over time, as if more hormone meant more protection. With each refill, DES shifted further from a lab-made chemical into something that felt routine, almost reassuring in obstetrics. But that routine came with a blind spot. The focus stayed on the immediate goal: preventing pregnancy loss in the mother. The fetus, developing day by day under powerful hormonal signals, rarely entered the risk conversation in any serious way. Doctors and patients acted on what sounded logical, not on long-term proof. DES became a standard intervention before anyone truly knew what it changed inside the developing child. By the mid-1940s, the promise around DES met a basic test. Did it actually stop miscarriages? Researchers ran more controlled studies, comparing women who took the drug with women who did not. The results disappointed. Miscarriage rates did not drop in a clear, reliable way. In some cases, outcomes looked no better at all. The central claim began to wobble, but the drug stayed in motion. That gap between evidence and practice did not close. Many clinicians had already built DES into their routines, especially for patients labeled high risk. The logic felt simple, even if it was unproven. If hormones supported pregnancy, more estrogen seemed like extra support. And once a treatment sounded reasonable, stopping it felt like taking something away. Habit mattered, reputation mattered, so prescriptions continued, even as the data failed to confirm the benefit. DES also spread because medicine moved through networks, not just journals. Training programs passed down what senior doctors believed. Articles and conference talks repeated the idea, often louder than the negative findings. Drug makers kept supplying it, and demand stayed steady. The result was a quiet drift. A medication with no demonstrated power to prevent miscarriage became normal care. The belief held on. The use expanded and more pregnancies were exposed. By the 1950s, DES no longer sat at the edge of obstetrics. It moved into the center. Drug makers promoted it as a modern answer for pregnancies labeled high risk, a broad category that could mean bleeding, past miscarriage, or simply anxiety about losing a baby. Doctors wrote prescriptions earlier and kept them going longer. A hormone that had started as an experiment turned into a standard precaution. The logic felt simple at the time. Pregnancy depended on hormones, so extra estrogen seemed like support. So DES got folded into routine prenatal care, sometimes in rising doses across the months. It reached women who never would have been treated years earlier. And because pregnancy care scaled up after the war, the numbers climbed fast. Each prescription also meant something else. A fetus received the drug too. That exposure mattered because it happened during the most sensitive windows of development, when organs formed and reproductive tissues took shape. Yet DES carried the comfort of authority. It came in tidy pills, backed by marketing and reinforced by habit. Millions of mothers took it, believing it protected life. Millions of unborn children absorbed it without choice. The consequences remained hidden, but the reach of the drug kept expanding. By the late 1960s, gynecologists and pathologists started seeing cases that did not fit the usual pattern. Teenagers and women in their early 20s arrived with unusual bleeding, painful exams, and problems that normally appeared much later in life. Some had cervixes that looked strangely shaped. Others had vaginal tissue that seemed out of place. These were not common findings, and they kept repeating in patients who were far too young. At first, each case looked like an isolated medical oddity. Doctors checked for infections, injuries, and anything that might explain the damage. The usual causes did not line up. Many of these patients had no history that matched what their bodies showed. Then another detail started to surface. The abnormalities often appeared together like a cluster, not a single defect. That pattern suggested a shared origin, something that acted early before birth. That idea carried weight because the reproductive tract formed in the womb during a narrow window when hormones guided development. If that process got disrupted, the result could stay hidden for years and only become obvious at puberty or with a first pelvic exam. The timing fit the mystery. These young women looked healthy as children, then showed signs of a deeper change later. The question shifted from what happened to them to what happened to them before they were even born. In 1971, the pattern that had worried doctors finally snapped into focus. A cancer that almost never appeared in young women, clear cell adenocarcinoma, kept showing up in patients who seemed far too young for it. Researchers began tracing their histories back past childhood, past birth, to the pregnancies themselves. One detail repeated with disturbing consistency. During those pregnancies, many of the mothers had taken DES. Once that link surfaced, the investigation widened fast. It was not only a single rare cancer. The daughters exposed before birth showed other abnormalities too. Changes in the cervix and vagina, unusual tissue patterns, and reproductive tract problems that did not fit the usual explanations. The timing mattered. These injuries traced back to fetal development, when organs were still being formed and hormones helped guide the blueprint. The conclusion landed with force. A drug given to protect a pregnancy had altered the child for life. It meant the risk did not end at delivery, and it did not even wait until old age. A decision made in a doctor's office years earlier now carried a cancer diagnosis in adolescence or young adulthood. In 1971, prenatal DES exposure stopped being a suspicion and became a documented cause. After the 1971 cancer link, the question stopped being whether DES worked and became whether it ever should have been used at all. In the early 1970s, regulators and professional medical groups moved step by step away from it. Advisories went out warning doctors not to prescribe DES in pregnancy. Some clinicians stopped immediately. others hesitated, trapped between old habits and new evidence. The message reached families in a different way. Mothers who had trusted their doctors began hearing that the same pills meant to protect a pregnancy might have reshaped their children's bodies before birth. Young women learned that their cancer risk and fertility problems had a name and a source. Anger followed confusion. This did not look like bad luck. It looked like harm caused by medicine itself. As the early to mid-1970s continued, lawsuits spread across the country. Patients sought answers, records, and accountability from doctors, hospitals, and drug makers. Courtrooms forced private medical decisions into public view, and the details sounded grimly simple. Studies had failed to prove benefit years earlier, yet prescriptions continued. The outrage was not only about what happened, it was about how preventable it seemed. By the late 1970s, the problem no longer fit neatly into one diagnosis in young women. Follow-up clinics tracked families for years, and the questions widened. If DES could reshape a daughter's reproductive tract before birth, what else could it alter? Reports began to stack up from men who had been exposed in the womb. Doctors saw patterns that sounded familiar: developmental changes, fertility worries, and anatomy that did not form as expected. Researchers compared DES-exposed sons to unexposed men and kept finding differences, not always dramatic, but persistent enough to worry clinicians. Some studies linked prenatal exposure to higher rates of undescended testicles, cysts, and changes in the penis or urethra that sometimes required surgery. Questions about sperm quality and infertility followed. The message landed slowly, then hard. DES had not targeted only female organs. It had interfered with basic reproductive development. Then evidence reached back to the women who took the pills. Obstetric histories showed more complications than expected: pregnancies that ended early, premature births, and ectopic pregnancies. Some mothers faced higher risks for certain cancers later in life. These findings shifted the meaning of the scandal. DES had not produced a single tragic outcome in one group. It had created a ripple of harm across bodies and across time inside the same families. By the 1990s, the immediate shock of DES had faded, but the consequences had not. Exposed children had become adults, and their health questions had changed with age. Researchers followed them for years, not weeks. They tracked fertility, pregnancy outcomes, cancers, and chronic problems that appeared slowly. The lesson kept repeating: a drug taken for a few months could shape biology for decades. Short trials no longer looked sufficient. As those follow-ups accumulated, the science pushed beyond DES itself. Investigators saw that hormones did not need to kill cells to cause damage. They could misdirect development. That idea helped sharpen a broader concept: endocrine disruption, where chemical signals got scrambled at the wrong time. Timing mattered as much as dose. A small exposure in the womb sometimes carried more weight than a larger exposure later. The old safety logic began to crack. Advocacy groups kept pressure on medicine and regulators to treat this as a lifelong issue, not a closed case from the 1970s. They pushed for registries, better patient notification, and clearer guidance for families. The focus shifted toward the fetus as a patient whose risks would unfold across a lifetime. Drug safety thinking moved toward long-term tracking and reproductive outcomes. DES stood as proof that waiting for obvious harm meant discovering it too late. By the time the decades of follow-up arrived, DES stopped being treated like an old prescription mistake and started being treated like a warning label for all of medicine. People who had been exposed before birth still carried a different medical reality into adulthood. Many needed doctors who understood DES-specific changes, because routine checkups missed what mattered: The drug's story stayed active, not historical, because its effects kept showing up later than anyone expected. For many survivors, care meant specialized screening, not just once, but repeatedly over a lifetime. Some faced uncommon cancers, unusual anatomy, fertility problems, and pregnancy complications that demanded careful monitoring. Others lived with questions that never fully closed. The science answered a lot, but not everything, and uncertainty became part of the burden. DES turned prevention on its head. A medication given to protect pregnancy ended up creating medical risk that stretched across generations. That lasting risk changed how doctors and regulators thought about safety. It pushed a hard lesson. When exposure happened in the womb, the clock did not stop at birth or even at childhood. Harm could surface decades later, and the people affected could not simply move on. DES remained a landmark because it showed the cost of confidence without proof. It stood in stark contrast to the late 1930s belief that a simple synthetic hormone could safeguard pregnancy.